and we are happy that we work as part of a team. We have a couple of physical therapists and occupational therapists who are also certified in Parkinson's in what's called the BIG program. The first thing we want to talk about today is just kind of an overview about communication and why it's complex what happens to people when you have Parkinson's disease. So just thinking about how we communicate, it requires a lot of interaction between our brain, which is where we formulate our ideas and our words, and then the actual speech production or motor system. And Parkinson's can actually impact both of those systems. Whoops, we went black.
Is that your program?
Nope. Not sure what that is. Okay, we'll keep talking. So when we think about speech production and just think about your own body, we start, our lungs are kind of the air supply for our voice. And as we move up above those are our vocal cords. And our vocal cords have to take the air that we breathe and we're kind of trying to push out and make sound with it. And then when we get the sound past there, our lips and our tongue have to shape that sound. So again, any one of those systems can be involved. And our brain controls the whole thing, okay? And we know that Parkinson's starts in the brain. Okay.
It's on here.
So when we look at Parkinson's disease, the lungs, people can have kind of shallow breathing sometimes with those muscles if they're not really getting a lot of good air supply in and out. Our vocal cords can get kind of soft, strained, and monotone.
It's up if you want to.
We're up, okay?
Which screen are you on?
Let's see here, we'll just go to the next one. Yep. Now we're together, guys. Okay. There's something at the very back of our mouth called our soft palate. It's kind of the area, it's right near where if you put something in your mouth and gag, it's right above that area. And that is a muscle that has to come up and actually help close off your nose so that air or food doesn't go through your nose. That can be involved with Parkinson's. And then our lips and tongues can be involved in terms of having difficulty because of muscle weakness or control, shaping sounds so that we can get that kind of slurred speech or more masked face that they sometimes talk about with Parkinson's. So you might say to yourself, do I have a problem that I should be thinking about maybe doing something about? So asking yourself a few of these questions if you are a person who has Parkinson's. Do I run out of air when I talk? Do I have to repeat what I say? That's usually kind of a big hallmark one. Do others say I mumble? Do others tell me to speak louder? Is my voice monotone or have very little expression? Do I avoid talking in person or on the phone with people? And do others have difficulty understanding me, particularly in noise? So as Parkinson's progress, many times these are some of the ways that people begin to see they're having some difficulty with speech. You know, everybody, we don't have one size fits all, but some general ideas about talking and Parkinson's. Trying to keep really moving your mouth a little bit more can be what's called over-articulation, thinking about how an actor talks. If they have to project to the back of a room, they're going to really move their mouth more. Trying to increase your volume to keep it up a little higher, but not shouting, okay? Staying hydrated, you might say, what does that have to do with talking? Well, we have muscles that need lubrication, and when they get real dry, many times it can get hard to get our voice on. Our swallowing and our talking system really use the same muscle set, a lot of the same muscles. So if you're coughing a lot, that can actually make it harder to talk because your voice can get kind of raw and irritated. So we really advise talking to your doctor. If you get a lot of extra saliva in your mouth or very dry mouth, sometimes there's things that can help with that which can make it a little bit easier to talk. One of the really important things is if you have a pretty quiet voice it's really important to pay attention to when you're talking, particularly if it's something important that you need to have heard. So turning off that TV in the background, reducing the noise can be real helpful. And just sitting up straight and looking at face to face. So many times people will say, you know, I don't understand him if the TV's on or if he's not looking at my face. When we stand and talk face to face, we get a lot better chance of having the listener's attention, which can improve your chances. Partners, same kind of things, just kind of doing a bit of a mental checkoff. Are we face to face? Is the noise down? Giving the person time to be patient and to give them the time to respond. I'm sorry, let me get to the next one. There we go. Sometimes I'll say to folks, it's not just the person who has Parkinson's that may need to have their hearing checked, but if you're a listener or someone with a soft voice, you might need to have your hearing checked, okay? We think about if we have poor vision, of course we would wear our glasses, but having poor hearing, that's one of our major senses, and kind of keeping that going as long as possible is really important. When you're talking to someone, if you're a caregiver who has Parkinson's, making sure that you give them feedback whether or not you understand what they're saying. Paraphrasing. So I heard you say that you want your medication now. Is that what you said? You know, just so that they get that feedback. And being honest. Have any of you in the room ever pretended like you understood what your partner was saying when you didn't? Because that, you don't really want to do that, because that does not give them feedback about how are they maintaining their intelligibility. Okay. If you have some difficulty with your speech pathologists or speech language pathologists are trained to assess and to treat both the speech, cognition that Tammy will talk a little bit more about, and swallowing. Most of us work in settings like hospitals or outpatient clinics, so that and in dealing with the insurance, we do need to have a physician's order to be able to see someone. But we really encourage to start early. If you're starting to have some difficulty with your speech or your swallowing or your cognition, to kind of get in early and learn how to manage it. Okay. Some of you may have heard of the Lee Silverman voice therapy, or LSVT. Lee Silverman is a woman who had Parkinson's, and she developed a foundation to help other people with Parkinson's in particular who had difficulty with speech. And so she really wanted to find what was the best program out there. And so Lee Silverman voice therapy is a specialized way of treating Parkinson's disease and the speech problems in particular, okay? With LSVT, it's a very intensive program that you're evaluated first to see if you meet the criteria for the program. And then you do 4 days a week for 4 weeks, an hour at a time with practice at home. And then after the program's done, there is actually the expectation to be able to maintain this louder voice that you continue to do practice at home. It's very much based on what's called the theory of neuroplasticity, which is really trying to change the motor system. Some of the studies have shown that with Parkinson's, many times people are getting some false feedback from their motor system. It feels like they're being loud, but the other people listening don't hear them as loud. Movements may feel big, but the movement is actually getting smaller. So you're trying to recalibrate your system, your motor system, with this program. Okay. And as I said, people do need to be screened for this because there's program criteria. You have to be able to read out loud. You have to be able to remember to practice. So there's some times when people are more appropriate for the program than others. And in general, getting in a little bit earlier than later tends to be helpful. Okay. If you live in an area that does not have LSVT certified speech pathologists, it's a training course, and then people have to maintain their skills with it. The LSVT has come out with a program called eLoud, and people can certainly look at that on their website. However, we do have to caution folks that most often insurance companies are not covering this because the person is at home with their computer and the therapist is in another site. So a lot of times insurance simply will not cover it. But it's something that I think that a lot of the therapy groups are continuing to try to advocate for to help get better access to people for services. Many times if there is not a speech pathologist who's LSVT trained in your area, talk to them about their experience, talk to other speech pathologists may be able to help as well. Even if they're not trained in that, they can kind of show you some techniques and some compensatory things to do. And then, just talking to Kathy here, we were saying one of the most important things that you can do is keep talking. Many times it becomes sort of a self-fulfilling prophecy with Parkinson's, that people get more and more socially isolated, so they stop talking much, and pretty soon their voice gets quieter, and then they're not out more, and it can kind of spiral that way. So thinking about anywhere where you can keep involved. Another option is a voice amplifier. And a voice amplifier is really a microphone that you carry around. Let me show you just a picture so you have an idea. We'll come back. It looks like that, okay? So you carry it around on your waistband. This happens to be one called a Chatterbox. There's another one called an Advox, several others that are out there. They are strictly there to help amplify your voice. So they can be very helpful if you have a very quiet voice, but your words are not slurred and you're able to think about what you want to say. If your speech is very slurred, it's going to just amplify and make that slurred speech louder. So sometimes it needs to be a combination. These are covered by insurance companies most of the time with a doctor order. They run around $200. So we've actually worked with a durable medical vendor in our area to have these available for folks. We've looked at ones that we definitely wanted ones that had at least 5 watts of power and had batteries that could be recharged. So something to think about. Okay. And the last area I'm going to mention is talking on the phone. Now, the little speech amplifier that we looked at, we have patients who will actually wear their personal amplifier, and they'll use a speakerphone. And many folks have a speaker function on your phone at home that allows you to then be heard by the listener on the other end. Okay, phones you can also get phones that amplify your voice. So I think a lot of people are more familiar with phones that amplify the person who's talking to you, but you can get voice amplifiers on phones. If someone truly cannot talk, but they can type, speech relay, and most of the carriers these days legally have to help set folks up with a relay system, so that I think we tend to be more familiar with it for folks who are deaf, for example, who will type in something and then the operator conveys the message across. And nowadays there's beginning to be some really interesting things out there with computers and smartphones, Skyping. Many of you who may be in more rural areas may be more used to Skyping with family or friends. And the plus for the person with Parkinson's is that if your speech is a little imprecise or kind of quiet, many times being able to see your face helps the person who's listening to you. They also get the advantage of really being able to know what you're feeling a little bit more than just a voice. Okay? So I'm going to turn this over next to Tammy, who's going to talk about cognition and language.
Okay. So hello, everyone. Welcome. And to everyone who's in the remote audience, I want to welcome you guys. So what I'm going to talk about is cognition and language. So Pat talked about the production of speech. It's our bodies, our muscles making those speech sounds. What I'm going to talk about is where that starts, is that we start by thinking about these things, and then we put the words together and in the right order to talk about these things, and that's where cognition and language in Parkinson's plays a part of that. So what is cognition? Oh, yeah, thank you. So what is cognition? Cognition includes the language skills that we need to have, finding the right word when we want it, putting it in the right sentence, thinking and planning. I mean, for later Parkinson's, what am I going to do today is a big planning experience. For earlier Parkinson's folks, it might be maybe they want to build a shed, but that shed gets where they have to think about every little step a little bit more. It includes the ability to learn new information, our memory. What did I do last week? What did the doctor tell me? Sequencing, and again, that goes from, what step am I in the middle of when I'm making my coffee to, can I build this shed, and what are all the steps you need to do that? Problem solving, coming up with solutions to problems, and then attention and concentration. To be able to get anything done, you have to first be able to pay attention to it, and that can be one of the things that changes in Parkinson's. So it is known that cognition changes with Parkinson's disease. The very first thing that changes is literally a slowed thinking. You just can't get those words fast enough. Problems seem to take longer. So they have an impact on our everyday lives. Activities of daily living, that's a term we use to describe dressing, eating, bathing. Higher level activities of daily living are managing your checkbook, writing bills, that kind of stuff. And if we think about remembering to take your medications, and if we think about how cognition can interfere, or lack of memory, how that can interfere with that. So managing finances, social interactions. I want to say this, and I want everybody to hear this. One of the biggest indicators to cognitive decline, or one of the biggest predictors of cognitive decline, is lack of social interaction. People start withdrawing. It takes, every conversation we have is an opportunity to think about what we want to say, to connect with somebody. And I just want to really reiterate, the more you socially withdraw, the more likely that cognition is going to change. So keep talking and keep thinking is the big message here. Reading, writing, and talking. All those things can be impacted by changes in cognition, interpersonal relationships, and then even complex tasks like driving. Driving is, you have to pay attention, it's a multitasking experience. You are turning a corner, looking for pedestrians, and all at the same time remembering where you want to go. So there is something called Parkinson's dementia. And it occurs when a person with Parkinson's develops cognitive problems, and the other reasons for these changes have been ruled out. It differs from other dementias such as Alzheimer's, vascular types of dementia, and then the Lewy body dementias. It's usually not seen till later in this, 10 to 15 years post-diagnosis. And what I want to also tell you is there are things you can do to kind of stave it off. Or you keep thinking, keep doing anything that makes you concentrate, anything that makes you solve problems. And the estimate is about 20% of the people who have Parkinson's disease will develop the Parkinson's disease dementia. So what are the symptoms of Parkinson's disease dementia? Like I said, it's earlier, the memory problems, distractibility, having a difficult time concentrating. Slowed thinking is typically the very first thing that we're finding is a sign of that change of cognition. Disorientation. I think when you're retired, you don't necessarily know the date so much, but you know the time of year. So I wanted, am I forgetting to do that? Okay. Confusion. It can be even like just outright confusion. Moodiness. The frontal lobe of the brain helps those emotional things not get out of control. So you might find yourself getting a little bit more moody because that frontal lobe isn't helping you control that. Lack of motivation. It can be hard. You might know what you want to do, but not get yourself to do it. And then later on, it's hallucinations. To diagnose Parkinson's disease dementia is a medical evaluation is recommended, and what they'll do is they'll review the history. What did it look like 2 years ago? What did it look like 5 years ago? They'll review your medications, because sometimes you can be overly medicated or not be on the right medication, and that can help you eliminate some of those cognitive changes. A neurological examination, a laboratory test to rule out vitamin deficiencies or malnutrition, brain imaging, and then mental status testing. We do a lot of cognitive testing as speech therapists, and we will evaluate each area: memory, problem solving, even just how well we can pay attention. So normal aging versus dementia. I have a lot of patients who they talk to their loved ones, and their loved ones will say, well, I forget stuff too. And it's really a little different. In normal aging, okay, thank you. In normal aging, thank you. We're usually aware of the moments when we forget things. We might have an occasional search for words, but we don't get lost in places, in familiar places, but we might have to pause to think about, well, where is it that, how do we get there? And then our interpersonal social skills are intact. Dementia, really the folks who have that later kind of dementia, they're only concerned about the memory loss if it's brought to their attention. They don't notice it. Frequent word finding difficulties or substitutions are happening more often. Getting lost in a familiar place. A noticeable reduction in the recall of events, not knowing that you maybe even went to a doctor's appointment the day before, or much less the information that was presented. A loss of interest in even social activities, and one may even behave in socially inappropriate ways. So a speech pathologist can evaluate how things are and give you information about, where are you in terms of your cognition. They can provide therapy if it's appropriate. We can give people and families ideas for management, no matter what stage of the dementia you're at. If it's early stage, we might say you need to do way more activities that challenge your brain, and later we might be giving caregivers more information about, well, when the sun goes down and they get a little bit anxious, how do we help with that? And we can also help reduce some of the frustration and the misunderstanding about the behaviors that are happening. So memory helpers. Let's talk about some of the things that help our memory. Low-tech memory helpers are writing down lists of things. We might have always felt, well, I never needed to write a list before, but why not? If it helps you remember the 5 things you want when you get home from the grocery store, instead of ending up with just the 4, I would write a list, and I recommend people to write a list as well. I love the day planner, or even the weekly planner. That helps us all keep on track, and it helps remind us, what did we want to do today? Medication or pill boxes are wonderful for remembering, did I take my medications today? Well, if the pill box is empty, you probably took them. Following a schedule or keeping a routine is wonderful, because then the only things we have to really focus on are the things out of our normal routine. And then when we get into the later stages, a seatbelt on the wheelchair, just so that they don't think, oh, well, I've got to get up and go to the bathroom and then fall. Higher tech kinds of things are automated medication systems, phone alarms and reminders, bed alarms so that people don't get out of bed without something going off to remind them maybe it's not the safest thing. So what can we do to improve our mental acuity? Exercise is so important. And I'll say something even more. I went to a recent conference, and they said that exercising with people did even more than exercising by yourself. So again, there's that social piece, which I think does more than what we think it does, but we want to keep that in mind. Exercise, and if you can do it with other people, do that. Eat a brain-healthy diet. Omegas, fish oil, that kind of stuff, they know that it helps us think better and kind of stave off that change of cognition. A lot of what I encourage people to do is to challenge your mind. It's that use it or lose it principle, or if you want to call it neuroplasticity. In any case, the idea is that the less you do something, the less you're able to do something. The more you do it, the more you can do it. Again, that social interaction. Think of every single conversation you have as an opportunity to think and to give information and to learn information. Good sleep is really can't be emphasized enough. I know how I feel after I don't get a good night's sleep, and if you're not getting a good night's sleep, nothing works as well, and that does include our thinking. Stress is plays a huge impact on thinking, and if you can manage it, you'll remember more. And then certainly avoiding smoking and limiting your drinking. I will say, I just looked this up. 1 drink for women, 2 drinks for men, 2 drinks for men max. It's the people who go over that where it starts to have a detrimental effect. Okay, so sometimes the motor skills of speech are just too impaired to get the messages across. The communication skills aren't there. The cognition might have changed. And we have to think about, well, how can we help people who really can't communicate, right? So low-tech communication options are gesturing and pointing. I mean, that is one way that I know with some of my patients, I know what they need simply because they can point to it. An alphabet board is literally a board with the letters of the alphabet on it, and they can spell out messages if they are unable to speak them. A picture board works even better. You can just point to a picture and then you have like the whole idea or the message under the picture. So writing, I had one patient who we really did work on the LSVT program, but it did not work for him, and we had all of our conversations by writing. Typically we want to have, we try to reduce how much the caregiver has to do because we don't want to overload everybody, right? But the partner can be asking, is this what you want? Or is this what, asking yes or no questions and giving choices. The nice thing about, in general, these low-tech communication devices are they're low cost and they're portable. It's a notebook you carry with you with a lot of those commonly used phrases that you might need to say. The difficult thing is it's very limiting. It can't possibly have all the information you might need to say to someone. And it requires good motor skills. So then it brings us to the higher tech communication assistants. Non-speech devices are things like computers and keyboards and even phones. Smartphones have apps, and iPhones have apps that you can download, and they range from $3 all the way up to $200, and they can help people communicate. Speech generating devices are specific dedicated devices that produce either like pre-recorded speech, which you would have pre-recorded, or the computer itself generates speech. And the person who's using it would either type in the words and it would talk, or you'd have pictures with the device or with the message that says whatever the picture indicates. And this is for people who really are unable to get their message across any other way. Tips regarding assisted communication devices are to work with a knowledgeable speech pathologist and the vendors. There's a couple of devices out there that are really, they can do anything except maybe make your coffee in the morning. They just do so much, but that might be a little overwhelming to someone who doesn't have a skilled who doesn't have computer skills. And then there are some where you push a button and it's already doing what you want it to do. The other things that we have to consider are the motor skills, the spelling, the reading, vision, cognition. The needs of each patient are very different, and we would want to fit whatever device we would consider to be perfect for you and what you're able to do. For these devices, you have to have a physician referral or a physician order, and then the Medicare. So Medicare covers the device only for people who they consider medically necessary. Some of these devices can do more. Like one device is on a touch tablet, and it can connect to internet and email and Skype and all these things, but Medicare will only cover the portion of it that. They'll only cover it when it is used for a speech device only. But you can open that up, and whoever you would talk to would help you with that. Okay, so now Pat's going to come back. She's going to talk about Parkinson's disease and swallowing.
That works good. Okay, everybody awake out there? Stop and stretch for a minute.
Yeah.
You know, here we are talking about using our brain. We're going to take a second. Everybody stretch. Stretch out for a minute. Get that oxygen up to your brain. Oh, I see some good ones. All right. Oh, great. I'm not sure who we're watching on our monitor, but good job there, guys. Okay. So next we're going to talk about swallowing, and you might say sometimes we get patients referred to us and they go, well, you're a speech therapist, what do you have to do with swallowing? Well, as I mentioned earlier, it's a lot of the same mechanisms, and so generally speech pathologists have been trained in their programs, most of us masters or PhD, to really take a look at the swallowing mechanisms as well. And swallowing is something that we just generally don't sit there and think about, how do we do this, huh? I don't think most of us ever had a course in swallowing, right? How to do it. You learned it as a kid. But we're going to talk a little bit about what is normal swallowing, and again, how can Parkinson's impact that, and some ideas for you. So there's 3 phases that we call in swallowing. Okay, and I'll come back and we'll talk about each of these, but oral meaning kind of from your mouth, your lips to your mouth. Pharyngeal is more in your throat, and then the esophageal is actually in the tube where the food goes right before the stomach. Okay? A couple of terms so you know that if we talk about these, dysphagia, even though it's a G in there, it's dysphagia, just means difficulty with swallowing. Okay, all you need to know. If somebody ever diagnosed you with dysphagia, you got difficulty swallowing. Bolus, in speech and in x-ray where we work with folks, we talk about a bolus being something that sticks together as it goes down your throat. So if you chew a piece of food, it will hopefully mix in with your saliva enough and stay together so it can go down that little bolus, whatever that is that you use. Aspiration means food or liquids getting into your lungs. So particularly in later stages of Parkinson's, that can very oftentimes be something that lands people in the hospital, and we really try to avoid that as much as possible. Silent aspiration means food or liquid or even medication got into your lungs and you didn't feel it, so you couldn't help protect your airway by coughing. I'm going to ask everybody to cough. Okay. What you just did there was your vocal cords came together with pressure from your lungs to help push something out, and that's a protective reflex. Penetration means the food or the liquid, that bolus, got to the level of your larynx in your throat but didn't quite go into your lungs. Okay? So we're not going to quiz you in that, but just to get an idea as we bring those up. So in the very first stage of swallowing, we have voluntary control. Our brain can stop it. So for example, if food goes into our mouth we don't like, we can spit it out. Okay, that's the voluntary phase. So what happens is that, and you might want to just, if you have something in front of you yourself to swallow, you might want to try, or even just by yourself trying to do a dry swallow. Swallowing starts with our lips opening, getting the food or the liquid in. Your tongue has to elevate. It moves the food to the teeth if it's a food item. Your teeth have the responsibility of chewing it and help breaking it down. That food has to mix in with the saliva that sits in your mouth. And the saliva acts like an enzyme. It helps to break down that food so that if you're eating something really dry, it can stay together as it goes down in your throat. And then the tongue is going to collect all that food from the teeth, get it together, and then help move it back in your throat to begin the next phase of the swallow. The sensory system on your tongue feels something in your mouth and has to send a message up to your brain. So do you think about that every time you swallow? It all happens pretty quickly, but Parkinson's can impact a lot of different places in that whole part of the first or that oral phase. So if your lips are weak, you may have difficulty having a seal so that it doesn't, liquid in particular doesn't come out, because it's going to take the path of least resistance. Or you may find if you have a lot of tightness, if you're at that stage in your Parkinson's, that it may be very difficult to get your mouth open to get food in. The tongue, again, has to be, we don't think about our tongue being a muscle. We stick out our tongue, okay, but it's a muscle that's moving a lot in our mouth when we're swallowing, because it's moving the food over to the teeth, picking it up, moving it from the top of our mouth, moving it back, okay. You can have weak cheeks. Ever think about that, huh? Your cheeks can collect food, though. What we'll do is a lot of times have people swallow something and look to see after they swallow it, are there still pieces of that food sitting in the mouth or on the back of the tongue? I mentioned that your sensation has to really feel the liquid or the food in your mouth to send that message up to the brain to get things moving. Sometimes many of the Parkinson medications, for example, can make people feel pretty dry mouth. I don't know if anybody in this group ever has felt that, but that not having enough saliva or having a dry mouth can make it harder. So there are some products that are out there that can help also. Some Biotene, for example, makes a number of products that you can use to help add extra saliva. And we'll be happy to take further questions on that if you want to know more there. We mentioned that this first phase, this oral phase, is voluntary, which means you can stop it. Okay? Once it goes past the back of your mouth, you can't stop the food. But sometimes with dementia, what we will see if people are in a later stage of Parkinson's and have Parkinson's dementia, the brain can not be reading the signal well from the tongue. So they may can do things like be spitting food out because they're not getting a good signal that really is something they should be swallowing. So, and we talked about the saliva. Many folks will talk about they have dry mouth and yet they have a lot of extra saliva. What can happen is that the saliva sits in your mouth, and rather than automatically throughout the day being swallowed, it can pool in there and then sort of drip down when you open your mouth for drooling, or drip down into the throat and cause a kind of thing. So saliva management is part of the whole swallowing. Okay, so once we get the food in the mouth and beginning to go down, and there's that word bolus, the lips, the tongue, you can see that red, that's called the bolus, starting to come down into the throat, okay? And it's amazing, again, a number of things that have to happen at this stage. So the palate, and we talked about the palate being on the roof of your mouth way towards the back, that palate has to lift up and actually close off your nose so that that food or the liquid going back doesn't come out your nose. Something we don't think about. Okay, your larynx, and I'm going to ask you all to put your fingers right on the very front of your throat. If you've got something here liquid-wise to drink, go ahead, but if not, we'll try a dry swallow. And I want you just to swallow with your fingers on your throat. Okay, we're going to pick on the audience here in Kirkland. Anybody tell me what you felt? What'd you feel there? Karen says the little bump moved up. Good job. That little bump is your larynx or your voice box, okay? And what it is doing is automatically moving up and forward. And it's going to meet with the bottom of your tongue, which is part of your chin here, and help close off your airway to protect you so food or liquid doesn't go into your lungs, okay? So one of the things that we are always watching for is when we do a swallowing assessment with someone is feeling, is that, we call that hyolaryngeal, is that elevation of the larynx happening? Is it good and strong and protective? Okay. Then the pharynx, and that's kind of the throat. The throat muscles have to constrict and kind of squeeze down the food. So if your muscles are kind of weak, what can happen is, rather than squeeze that food completely so that it goes down into the next phase, which is your esophagus or your food tube, food can still sit on the inside of your throat after you're done eating or drinking. Having that feeling that there's something still left there is called globus. And many times the reaction, if all our sensory muscles are working well, will be to, or to try to get it out there because your sensory muscles are telling you, nope, you're going the wrong way. Okay, pills are, for example, one of the things that can get caught there. Okay, if everything goes from the mouth through the throat, the next place it's going to go is into the esophagus. And the esophagus is a little tiny food tube. Okay. And it's behind, actually in this picture it's a little bit harder to see. If you're seeing that little bolus where it says the pharynx, the next level it would go into is in the esophagus. And the esophagus is typically closed. And it takes the pressure from the food coming down into the throat to help open it. It has to feel it because otherwise it's closed so we don't get things coming back from our stomach. Also, when your larynx moves forward, it helps to prepare it by reducing the tension on the top of that little tiny esophagus so the food can go in. Once it goes into the esophagus squeezes the food down. At the bottom, it's also closed until the food comes in. That bottom opens, lets the food into the stomach, and it continues processing. So again, swallowing, when we do something, think about all those different muscles we've now just talked about that are involved. And you can have problems at any one of those levels. So the solution, or kind of the way to help manage that, really depends on where is it that you're having the problem. Some of the things that you might want to ask yourself if you're saying, am I having problem swallowing, are, am I avoiding drinking liquids? Do I have food left in my mouth after meals? And it's really good to check there. Actually, every once in a while, open your mouth and see, is there anything still sitting in there? Do I feel that feeling, that globus we talked about, that I feel like something's stuck in my throat? Am I coughing, choking, or throat clearing? So throat clearing again is that, you know, we may do that every once in a while, but someone who had, and particularly for those of you who are caregivers, if you hear your loved one continually do it, usually that's a pretty good red flag that you might want to be paying some attention to what's going on there. And another question about swallowing problems is, have you been losing weight a lot without trying? You know, one of the catch-22s that we see with people who have Parkinson's is that many times you don't want to get up because it's harder to walk to go get the drink of water, and you don't have to go to the bathroom, so pretty soon you get a little dehydrated, and dehydration can affect your mental status, your cognitive status, as well as your swallowing, because those muscles need liquid. They need to stay hydrated to be able to operate efficiently. And obviously, you know, I think one of the things happened, Tammy referenced, you know, that sometimes just some of these things happen slowly over time, that you just may find yourself being the last person at the food table, at the table, no matter what, that is just getting harder and harder to chew and harder to swallow and more work to eat. Sometimes that means maybe time to take a look at it, okay? People will ask us, when should I talk to my doctor about this? Well, some of the areas that would be sort of red flags to us that we would say probably a good thing to talk about with your doctor. If you're doing frequent coughing, that throat clearing, or if you have a lot of shortness of breath, if you notice a lot of drooling, if you have a temperature with any of those going on. One of the signs of infection many times is having a temperature can be kind of a precursor if you might be getting pneumonia, which means something, an irritant in your lungs starting to cause an infection. If you're having that feeling of that globus, that after you eat or while you're eating, that food seems to be sticking in your throat, probably a good idea just to mention that to your doctor and get that checked out. Okay. So generally what happens if you mention this to your doctor, they may order a number of different tests. They may order a speech pathologist to consult that will actually, in the clinic, Tammy and I will sit there and we'll bring in a meal for you. You'll have some liquids and some food and some soft food and some crackers, because we want to see what happens in that oral phase, in that pharyngeal phase, in the esophageal phase. We're pretty good about watching from the outside, but sometimes we really, for safety, need to get something called a modified barium swallow study, or a MBSS. That's a non-fasting study done in radiology where they actually use barium, which helps to be able to track what's happening to that bolus, that liquid or that solid, as it's going through from the oral phase to the pharyngeal to the esophageal. So we'll actually give you different thicknesses of barium to swallow, just a little bit of each. Give you a cracker, and in our facility we'll use like a cracker, we'll put some barium in with fruit. So we can actually see what's happening, and in particular if there's some concern about someone silently aspirating, meaning food going towards the lungs without feeling it. And very often that's a person who's been in the hospital a couple of times with aspiration pneumonia, or just sounds really gurgly a lot of the time. Another test that you may be seeing done is called the FEES, which is using a fiber optic scope to actually look down in swallowing. So in general, and again, just some things that I think can be helpful for anyone trying to be as safe as possible with PD and swallowing. Number one, sit upright. Don't eat at your recliner. One of the first things I'll ask patients, where do you eat? They'll go, well, I get tired, so I lay back in my recliner. If we're going to do CPR, the first thing we do to try to get air into the lungs is put the head back and open the mouth. And that's what happens when you're laying in a recliner. It's a great place to rest, but not a good place to eat. Laying back in bed, laying in a recliner, because you're opening up your airway. Much harder to swallow from those positions, okay? You don't, this sounds kind of funny, but you do not want to talk and eat at the same time. Many of us were told that when we were kids. There is a physiological reason for that. If you are talking, your vocal cords are opening and closing. If you're swallowing, they need to stay shut to help protect your airway. So sometimes we'll see people, particularly if they have dementia, who will put food in their mouth, keep putting more food in their mouth, and then try to talk. And that can be something where the family member has to really help them, or the caregiver really pay attention, because that's going to really set you up for potentially aspirating. Taking small bites and chewing well, adding extra moisture to dry foods. I would say, with both Tammy and I, when you see people that come in with even mild difficulties with eating, what a lot of times sort of the two ends of the spectrum will be having difficulty with dry food or with water. Part of it is that water has no flavor. and it goes down fast. So many times if people's muscles aren't reacting or their sensory system not as quickly, the water will make them cough and the dry food will get stuck. So again, trying to break down where it is that you're having that problem. A lot of times we'll say to folks, you know, avoid just having dry crackers. If you're going to have a grain cracker, stick it in some juice first. If you're going to have a meal, one of the ironic things is that I'm sure most of you who have Parkinson's know as your day goes along, do you get more tired or less tired? Probably more, right? And we have our softer meal in the morning when our muscles tend to be a little bit better. You know, we have the cereal and the scrambled eggs. And many times when we have our tougher meal in the evening, as the muscles are more fatigued, that's when you got the dry chicken or the steak. Sometimes we'll say to folks, you know, you may need to reverse that or have your bigger meal at lunch and less at dinner, or have a couple of smaller meals as opposed to fatigue factor with eating. And there was a study done looking at people who were coming into hospital emergency rooms for aspiration pneumonia, meaning getting food or liquid or pills into your lungs, which then will be an irritant and cause an infection that will lead to pneumonia. The number one thing that they found that people could do to help reduce aspiration pneumonia and getting into the hospital with this is after meals, brushing your teeth really well and using an electric toothbrush, much cleaner. So that particularly if you're someone who's having any difficulty with thin liquids, which will be often very early on in PD, if you're having difficulty, that saliva, you may actually aspirate and not feel. And if that saliva mixes with pieces of food that then go into your lungs, you have an irritant. So it's just being smart, thinking about really good cleaning out your mouth after you eat, an electric toothbrush if you can. A couple of tips for taking medications. I would say of people who, again, are kind of earlier on having some difficulty with swallowing, getting a pill stuck in your throat or in your lungs is just not good news. And many of you are taking a lot of medications. So thinking about just some really simple tips. Take one pill at a time. You may be thinking, I want to just get them all down. And I'm going to throw my head back to take them. But you want to take one at a time. If you are really unable to manage some of the large pills, which people have, or the big gelatin, talking to your pharmacist. Sometimes you can get substitutions of a liquid form of that, or you can talk to them, is this something I can cut up or crush? Often putting a medication in with something with puree that kind of helps it stay together and go down in the throat and not get stuck on the sides of the throat can be helpful. And sometimes if people are having difficulty just with the water in particular, or thinner liquids going too fast over the back of the tongue and going down before all the protective reflexes are there, using some thickener can be of assistance. So again, the speech pathologist will kind of work with you looking at what's going on and what would be the way to best manage this to keep you safe and feeling better. So on the last slide here, we have a couple of resources, and one we definitely want to thank is the National Parkinsons and the Northwest Parkinson's Foundation here for having us here today. So our message is truly keep communicating and keep swallowing. You know, sometimes people, I know that later on in your disease, talking and eating are work. But using those muscles, just like any other muscle, muscles will atrophy if you don't use them. So keep using them, including the brain. Okay, so we will stop and however you want to manage questions.
Right. All right, well, thanks, Pat, and thanks, Tammy. It's such important information and so critical to the issues associated with Parkinson's. And some of it, you know, I think probably sounds like common sense, but the added effects of Parkinson's make it so important to really take all of those tips and that information to heart and kind of think back on it when you're going through your daily life. Also, the resources that were up here, I think at the end, we might flip back to that at some point, and that, You know, I know some of you don't have access necessarily to speech pathologists where you may be located, but again, you can get a lot of good information, not necessarily talking with a speech pathologist, perhaps with many of these organizations, but keep in mind that's another great resource to try and access as you go through your daily life. So now is our opportunity to check in with each of our remote sites, and I have the list of sites. So what I'll do is call out each site, and as I do, if you have questions, please unmute your microphone to ask your question, and let us know if you well, we can have Tammy or Pat respond to your questions as we go through. So,
Go to Tammy.
okay, and if I didn't say it again, thank you very much. Excellent presentation. So, I know you can't see us, so we're just this disembodied voice. But let's start with Anchorage. I think Anchorage checked in this morning. Do we have any questions from Anchorage?
Yes, we have one person with something.
Uh-oh.
Hi. In our research, we discovered that we can get omega-3 and 6 from plant foods, such as flaxseed, flax oil. In fact, we ground them right before we mix them in hot cereal. We prefer hot cereal because it's healthier.
Can you guys hear that?
Chia
Okay, can I stop you and ask, whoever is asking that question, could you speak directly into your microphone? We can't hear you.
Okay, is this our microphone here?
I'm not sure, but it comes from the room, so let's speak louder.
All right, I'm just going to have to speak louder, maybe if I can't. In our research, we discovered that plant-based diet is better and in many ways than one. For instance, the source of omega-3 we use, the sources are flaxseed, we ground up, or flaxseed oil, and also for omega-3 and 6, chia seed. And there are also soy foods. You can have soy nuts, and there are vegetables like kale, many other there. You can even Google this online and discover them. But you can also put these in your salad or in your baked goods like cookies, healthy cookies. We reduce the sugar. We find that, of course, it irritates arthritis too, among other things. But we tend to eat plant-based diet. When he's taking his medication and he's hungry, I give him a very colorful salad with non-invasive stuff to go with it. We don't even put cheese in there, and he bounces up right away. We don't do protein with the medication, whether it's beans or meat. We've eliminated meat in our lives because it seems to be detrimental. And also with the memory, we noticed that if we listen to classical music and eat high-carb sources of food, this will enhance its frontal lobe function, the cognitive skills that you talked about. And like you say, walking, exercises is good also for that. And avoiding negative thinking, also, and stressors are anything that would be toxic to your life, whether or not you have Parkinson's, helps one function as a happier person. Of course, you get your depression with Parkinson, and it's difficult to avoid that sometimes when there are frozen moments. And when he falls, it hurts, but you have to think of ways that you can be lifted up. With him, he sings a lot of Christian songs, and that's also good for your frontal lobe. Anything that is classical or Christian music, that's what works for us, and it's worked for other people too. We've read a lot of research on this. Thank you.
Okay, so it sounds like you had a lot of good suggestions of what's working for you. Did you hear a specific question? Maybe we can respond to again. We have to go quite a few places. So.
Well, mostly I just wanted to say that it's really important to look up things that you feel like would help you. If you're not a person to socially exercise with people, then maybe those omega-3s, 6s would actually be what you would want to do. But of course, I do encourage the the exercise. So yeah, I think you're doing a lot of really good things. Some people have allergies to wheat-based foods, and to avoid them would be a good thing. So keep up the good work.
And from now on, we'll repeat the questions as best we can, or comments. I didn't think of it either, but it just sounds like, again, I think the point here too is to try a lot of different things. Know that what's working for someone else may not be working for you, but that you can experiment with a lot of these different ideas, and know that one way that you may be doing it is not necessarily going to be the way that it's going to always work every single day as you move forward. But whatever you can find to be your best effort is going to be the best way. So Kirkland, and we'll repeat the questions next time. Okay, thank you, Alaska. Let's go to Coeur d'Alene. Any questions in Coeur d'Alene?
Are there any questions? We do have a question. Just a minute.
Okay.
Are there exercises that can be ongoing that would strengthen the muscles through the throat?
Okay. Are there exercises that could be ongoing that would strengthen the muscles in the throat? Pat's going to answer for us.
There's a couple I think that are very good, very simple kind of things. And again, if you think about what you're using those muscles for, so just things like opening and closing your mouth. A nice one is to press your lips together to help keep the lips a little stronger. Put your lips and try to keep them together. And I know, I wish we could show this to you, but you can try this yourself. Put your lips together and then put your finger right below your lip. Okay, and what you're going to do is use your finger like a little resistive trainer, because your lip is one great big muscle, the orbicularis oris. So put your lips together tight, your finger under your chin, and then try to pull. And you're going to try to resist. Everybody feel that? Okay. You know, this is one of those, we're doing things like actually just sticking your tongue out, moving it side to side, trying to lick your lips are a good exercise just to keep things moving there. Putting your tongue way up as far as you can back in the back of your mouth is a good exercise, and just holding it for a second. And when you do that, feeling in your throat, you'll be surprised. You're really getting a good exercise. I always figured that's a good one too for double chins for us ladies, you know. So tongue all the way back and hold. Okay? Lip, if you think about all those little muscles just in the mouth that have to work, things like putting your lips in a big smile and hold. And part of the exercise part, good, we see some people doing a really good job here, yay! Part of it is the hold part. You want to stretch the muscle, and then bring, the opposite thing would be to go from a big smile to put your lips out like you're going to blow out a candle and hold. So like ee, ooh, but not fast, just get a nice good hold on them. We can't go in there and actually do a lot to strengthen in the throat per se, but one of the better ones for the very back, the base of our tongue, which is the very back of our tongue into our throat, one of the best exercises for that one is holding that tongue way in the back. You'll actually feel it down in the chin. Okay. The other thing that I say to folks, and I know Tammy and I, we happen to work with a couple of physical therapists and OTs, as I mentioned, who are trained in the physical therapy part of that Lee Silverman kind of set up a program called BIG, and somebody mentioned freezes. We find just whatever you can do, it really helps your voice and your swallowing to keep your upper body loose. So doing things like shoulder shrugs, stretching your arms out, lifting your hands up above your head, things like turning your neck side to side. Good, I see some group members doing it there. Because you want to maintain that range of motion. If you're many times when people begin to get where the Parkinson's is more advanced, everything kind of starts getting smaller. So your chest moves forward a little bit, the head moves forward, you get kind of looking down. And people lose a lot of speech volume if you're talking down at the floor as opposed to up front talking to your listener. So just paying attention. If you're at home and you do a lot of work on the computer, you can do things like stop and stretch. So keeping things stretched out can be one of the most helpful. Thanks for the question.
Okay. Thanks, Courtelaine. We'll move to Billings, Montana.
No,
Yeah, we're here.
we're here, but we don't have any questions. Thank you for the information.
Okay, thanks, Billings. How about Miles City?
We have no questions, but we enjoyed the speeches from the ladies.
Well, good. We're glad it worked for you. How about Pendleton, Oregon?
Hi, my husband have a Parkinson and he have a very low voice.
Okay.
And sometimes he have also slurred speech. Anything can you help me? Thank you.
Low voice and slurred speech. What can we do to help with regard to that? Okay, go ahead and mute your microphone.
Okay, so that low voice and that slurred speech is very common with Parkinson's disease because Parkinson's serves to minimize our movements, right? So, I mean, the first thing I would recommend is to go to, if you have any providers in the area, to go to the LSVT treatment to see if you're appropriate for that. But if you are not, I think the two things that I would say would be to get that really good breath support. Make sure that the power comes from your breath and not from squeezing the throat, right? So that would be the first thing I'd say. And the other thing is to move your mouth more, over-articulate the way Pat had in that first segment. So really good breath support because the power comes from our breath. And then the other thing would be to over-articulate. Make that sound as clear as you can, as if you're an actor on a stage projecting to the back of the room. Does that help?
Yes, thank you very much.
Good, good. But that LSVT program, I think, would be the best thing to do.
Okay, okay. Thank you. Thank you very much.
You're welcome. Okay, how about
Hi, this
Clarkston?
is Pendleton real quick, and we had 7 and a dog. Sorry.
Oh, Pendleton had 7 and a dog? That's excellent.
That's correct.
Okay, good. I forgot to ask at the other places. I may come back to that. How about Clarkston?
Yes, hello, thank you. We have 16 attending today, and we have 2 questions. More than one of us, I think, have these questions.
Okay.
First one would be about biting the inside of my mouth. Are there any exercises I can do to help me avoid biting the inside of my cheek and lips? It seems on average at least once a week I am biting quite a bit.
Okay. You want to run the second question by us too, and then we'll have them both?
Sure. Okay, the second is for Tammy, for sure. Does the development of dementia parallel the loss of bodily functions, or do they develop sequentially or just totally randomly differently?
Okay, so Pat's going to answer the first one.
Thank you.
On the first question that came from Pendleton, is it?
Pendleton.
Pendleton, okay, was talking about biting the inside of the mouth. Clarkston, sorry. Biting the inside of the mouth and the cheek and the lips. You know, some of that can happen if people have some reduced sensation. So our muscles all have a motor aspect to them and a sensory, meaning the feeling as well as the movement itself. I have seen people do that sometimes if you have dentures that are poorly fitting. Sometimes that can make it a little harder. And sometimes, again, if the mouth is really dry, that can make you more likely. We were talking about the saliva kind of issue. There's a number of products that are out there, and let me just mention that one here. If you have dry mouth, Biotene, which was actually a company that I think started most of their products for people with head and neck cancer who had very dry mouth because of the treatment. Biotene has a spray that you can use it's actually an artificial saliva. You can spray inside of your mouth before you eat, which can help lubricate your mouth a little bit so things don't get stuck. They also have a gel that you can use. And nowadays they've come out with 2 different kinds of gum, so people can use the gum to chew, which is a good stretch of muscles, but it's also a gum that helps to actually create a little more saliva, again, for dry mouth, which can help. As we said, that saliva is an antibacterial as well as an enzyme to help break down the food so it doesn't get stuck. Okay?
Okay. And the other question was, does the cognitive changes like co-occur at the same degree as the motor changes? And I will say to some extent there is a connection there, but not always. I have a gentleman now who I'm working with who his swallow problems happened years before his diagnosis, and typically that happens a little later as well. And so it doesn't always happen that way. You know, this gentleman is completely cognitively intact, maybe some minor changes, but he didn't come to me for that, so I didn't evaluate it. But his swallow symptoms are relatively severe. So though it can occur at, it does kind of co-occur at the same time, it doesn't necessarily go that as, you know, when you're very severe in terms of your motor movements, that you will also be very severe in your cognitive skill. It doesn't always go that cleanly. But I will say, like early on, you know that we kind of don't think about it, but that slowed thinking should be one of the things you're watching out for as the disease progresses.
Okay, thank you.
Does that answer your question?
Yes, thank you.
Okay, good.
Okay, so Clarkston, thank you. Let's move on to Colville. Any questions from Colville?
We have 3 today and no questions, but thank you for the excellent information.
Okay, thank you for checking in. How about Dayton?
Yes, we enjoyed the program very much, and there was 2 of us in attendance today. Nice program.
Okay, and no questions? No questions, huh?
No questions.
Okay, thanks. How about Kennewick? Any questions from Kennewick? All right, how about Moses Lake?
Hi, there are 2 of us, and I do have one question.
Okay.
Is there any type of a reminder for pill giving? Whether it be...
Okay. A reminder for pill giving. And looks like Pat's going to answer.
We're taking turns.
Okay.
Okay. So the question was, is there any kind of type of reminder for pill taking? So
Correct,
there
yes.
are. I have seen everything from nowadays, you know, I know a lot of people, more and more is getting consolidated, and Tammy talked a little bit about the smartphones, but even the basic phones, most of them have a system where you can set up an alarm. So one of the most basic thing is to take your telephone and put in, you know, at 8 in the morning I have to take, you know, and I know that many of you take pills a lot of different times during the day, but you can set it so it just gives you a reminder the same time every single day. You just have to put the reminders in once and it stays in your system. If you're at, and that's really, those work really well for people who are out on the go. Tammy, when we talked about the cognitive, we were talking a bit about using pill boxes. What I get worried about is when people are telling me that they're set up their pills on a shelf or something and then they take them out of there. You don't really know whether or not you've had your medication. So using a pill box so that you can go back and look is, I think, one of the better things. I noticed there are more, there's some fancier pill boxes that are out there nowadays that actually someone can set them up. Like if a spouse is going to work and the person's at, your person who really needs to take medication is at home. Some of them have automatic reminders and it'll open the drawer. I see some head shakes. Any of you using those? For a brief time, okay. And again, if you have any access to the internet, just go on there and look at pill boxes. I'm trying to think, there's a website, what the name of it is. I'll hopefully think of it here before we're done, but just going online, it has a lot more senior products. But I think that more and more of like even the local pharmacies talking to Walgreens has some of those kind of things and looking at what really is going to work for you.
Well, we use the pill boxes, and they're great. It's just that time gets away with us.
Yes.
And I know it's important.
Do you carry a phone with you at all?
I have a cell phone, yes.
Okay. The other thing is, nowadays, again, I know a lot of people are used to the, the systems for, I fell and I can't get up, using some of the Lifeline kind of systems. But the other thing is, if you have that phone with you, that would be the place to put in those reminders, to maybe put in the appointments if you can. So again, you get a reminder on that. But also, if you need emergency help, if you carry that phone with you, that's sort of your one thing to really think about. And a lot of people, the place that folks are most likely to fall is in the bathroom. I mean, literally bring your phone into the bathroom if you need to. But I think sometimes relying on our memory when you have to do a lot of things, why not use a system that's going to help just give you a little reminder? So,
well, my husband's the one that has the Parkinson's, but I need the reminder for the pills too.
Well, it puts a stress. Both of you are living with Parkinson's, right?
Right. I think that's probably with everyone, but yeah.
You bet.
Really enjoyed your program today. Thank you. There's just two of us here today.
Good to have you.
Okay, thanks. I've got that down. Let's move on to OMAC, unless I called OMAC. Any questions from OMAC? Okay, let's check into usually our biggest room. That would be Spokane. How many do you have at Spokane?
Spokane has 32 in attendance today. And before we get into questions and comments for our speakers, I'd like to introduce Dr. Josh Neumiller from the Washington State University College of Pharmacy. All of these sites should have received a survey, and Dr. Neumiller will say a little bit about that survey now.
Thank you very much.
Okay.
And I'll certainly try and keep this very short, as I don't want to eat into the question time. But my name is Josh. I'm a faculty member in the College of Pharmacy at Washington State University. And I know here in Spokane we passed around an envelope that has a brief survey inside. And we did send out surveys to the other sites, so hopefully those were received. If not, we'll work on logistics and try and get those out hopefully for the next meeting if those weren't received for you folks. But quickly, I work with Dr. Lindy Swain, as well as some other folks here in town. And one of the areas of interest we have in terms of research and education is how people with Parkinson's disease, your experiences in the hospital in terms of medication administration. And so we've done a little bit of work in the hospitals in terms of educating the nursing staff about the unique needs in terms of medication timing and that sort of thing with Parkinson's medications. And as we've been working through this, it dawned on us that we would really like to hear from you folks, both people with Parkinson's as well as caregivers and family members, about your experiences, which is where this particular survey comes into play. This is an anonymous survey, so we don't necessarily want to know anything specific about you, but we do have 9 very brief questions here. If you'd be so kind as to answer those for us. Certainly it is a voluntary survey, but we feel it'll give us a lot of information about your individual experiences, and then we can hopefully take that back and really fine-tune some of our research and education efforts in the hospitals and within the community to try to increase awareness. We also, on the back of the survey, it is double-sided, have about 3/4 of a page for you to write any other thoughts you have about the issues or any stories that you think we may find of use as we work on this area of research and improving inpatient management of medications. So thank you very much, and I'll pass it on for questions.
Thank you, Josh. Do we have any questions here, comments in Spokane? Okay.
Hi, I just was visiting my dad in a nursing home back in Ohio, or back in Michigan over the weekend, and we brought him back from dinner, and the nurse said, "Oh, Bob, it's time to take your pills," and she had him put his head back, and she threw 6 pills in his mouth, and my son and I just looked at each other and thought, well, but I think I learned something here today. He's been in the hospital with pneumonia, too, several times.
Wow, that sort of shows what can happen. So now you can perhaps step in and help him change that behavior.
In reference to the woman who asked about the reminders for medication, yes. There is a watch available. Excuse me. There is a watch available that will beep and tell you that, and speak and tell you that it's now time to take your medication. And for the one who bites the inside of his mouth, if that happens at night, it could be due to grinding your teeth, and the dentist can make a night guard for you, and they work very well.
Great suggestions. I hope the other sites were able to hear that and check that out.
Okay, I think that's it for Spokane. Thank you.
Okay, well, thanks. I would also just second what Josh was saying in that I was just at a conference, and on a national level, there is work being done to see how to implement policies on a nationwide basis with regard to the delivery of Parkinson's medications in hospitals, because it's perceived across the country to be a significant issue and challenge. So for those of you that got the survey, we didn't get it here, but please do fill that information out. It'll be really valuable for the work that they're doing in the study. So thank you for that feedback. Walla Walla? Any questions? Okay. Tenasket. Anyone there?
There's 8 of us.
Okay.
There's 8 of us
any
here.
questions?
We don't have any questions. No.
All right. Well, thank you.
Thank you.
Port Townsend. No questions. All right, so I've saved the last here as Kirkland, and we do have folks here. Do you have any questions for us? Okay, no questions from Kirkland. So I think that we hit all the spots, except let me just ask, did I ask about Grangeville, Idaho? Okay, we have one more comment from Pat, and then I have one more announcement.
I just wanted to mention real quick, and thank you to the lady who had the idea of the watch. That's, I think, a great one. The website that has a lot of this kind of functional things like reminders and that is called Easy Street. Okay, set up for seniors in particular.
Okay, well, thank you again. Those were excellent presentations, terrific information. Thank you for being here, and thank you all of our sites. The one last announcement I wanted to make is that Northwest Parkinson's Foundation will be having a Hope Conference in Spokane on August 25th this year. It'll be our first time for a conference, an all-day conference. And we've got 4 national speakers who will be coming, as well as some local presenters. We would love to have all of you attend. The capacity is limited to 300 folks, but you can go to our website right now and go ahead and get signed up. There is a charge of $20 a person, but it's an all-day conference and you get lunch and other food and coffee. And we're really excited and looking forward to bringing our program out to Spokane. So check that out, and you'll be getting more information in the next month or so as well. So again, thank you all, and we'll see you next month.